Okay, so now we're going to shoot our left lateral rectum, and our SID is at 40 inches. It is lined up to my bucky. It is retented, and we're using a 14 by 17, or can use a 10 by 12 also. We're going to use our left marker for this. And the central ray is at the mid-coronal plane at the asses. Our asses is right there. There we go. There's your asses. And we are going to shield you. Here. And then the SID is at 40 inches. Okay, she is shielded. And okay, I'm gonna give you some breathing instructions, okay? And the technique that I would use, it would be 100 to 50 mass. And then I'm gonna give her some breathing instructions. It's gonna be at expiration. So, okay, Sylvia, I'm gonna have you take a big breath in and then blow it out and hold it. I'm gonna expose, beep. Okay, you can breathe and relax. And I'm gonna take out the film and I'm gonna go run it, and then we're gonna move on to our DQs. Okay, so now we are going to shoot our left lateral DQ, and we are at a SID of 40. We have our 14 by 17 plate. We are going to use our right marker. So we're going to put that right there. And we are going to center on our center ray. It is at the iliac crest. So here is our central ray at the iliac crest. And we're going to use a technique of 100 kbp at 50 mass, and we use our right marker since our right side is up, and we're going to use expiration, and we are also going to shield our patient before we start our breathing. There we go. So we shielded our patient. Okay, so now I'm going to give you some breathing instructions, okay? So I'm going to have you breathe in, and then breathe out, and then hold it, and then beep, and you can breathe and relax. We're going to take our plate, we're going to take it to the reader, and then we're going to move on. Okay, now we're going to do our right lateral DQ. So we are going to start by shielding our patient, make sure that she is protected, and we have our SID at 40. We have our 14 by 17 cassette. We have our left marker since our left side is up. Okay, so we're going to use a technique of 100 kbp at 50 mass. So now I'm going to give her some breathing instructions. Okay, take a big breath in, blow it all the way out, and hold it. Beep. Okay, you can breathe and relax. So we use that at expiration. I'm going to take the cassette, I'm going to go run it, and then we are going to move on. Now that we are all done with our overheads, we're going to remove the tip. So I am going to remove the clamp. So remove the clamp. And we are going to deflate the cuff. So where it's deflating. And then I'm going to have you take a big breath in. We're going to remove the tip now, okay? Okay. So take a big breath in. Blow it out, and okay, we're gonna take it out. Okay, it's out. So now I'm gonna have you sit. Okay, now that we removed the tip, I'm gonna have you go defecate the barium. So I'm gonna have you go to the bathroom. Okay. So the bathroom's right there. So go ahead and go defecate. So now that she defecated, we're gonna take our last film, and it's going to be a standard KUV. That's just to make sure that everything is out of the colon. So we are going to shield our patient. Very cool. Shielded her, and we're using a 14 by 17. We're going to put our right marker since we're doing our KUV. The cardiac crest. So it's right there. And it is at 40 inches SID. And now I'm going to give you some breathing instructions, okay? And then our technique is going to be between 90 to 100 to 30 to 40 mouths. Okay, so I'm going to have you take a big breath in, blow it all the way out, and hold it. Beep. Okay, you can breathe and relax. And then we are all done with that. So I'm going to have you sit up now, and I'm going to give you some instructions, okay?
Okay.
Okay, do you have any questions for me?
No.
No? Okay, so these are going to be the instructions. So you are going to see some discoloration in your stool. So you're going to see that when you go to the bathroom, it might be white, and that's just the barium. That's still in there might be coming out. And just drink lots of fluids, drink lots of water, keep hydrated. And other than that, no questions or anything?
No.
Okay, we are done. So have a good day, okay?
Okay.
Now that we are done with that exam, we are going to review our images, and we are going to double check that they are of acceptable quality and show any necessary anatomy. This is our AP scout. It's similar to a KUB, so you see all the way from the pubic symphysis to the diaphragm. And this is where the colon lies in these structures, but because you are not able to see the colon due to lack of density, once the barium is inserted and it coats it, we will be able to see it in the previous images. The importance of this image is to make sure that the patient is prepped and the colon is free of fecal material. If there is fecal material in the colon, it could obstruct and get in the way of any pathology that might be present. This is our PA projection of the large intestine. The PA projection shows the entire colon with the patient prone. The evaluation criteria would be evidence of proper collimation, entire colon including the flexures and the rectum. The vertebral column centers so that the ascending and descending portions of the colon are included, and the exposure technique that shows the entire anatomy. This is our PA axial projection of the large intestine. The PA axial projection best shows the rectal sigmoid area of the colon. The evaluation criteria is evidence of proper collimation, rectal sigmoid area with less superimposition than an PA because of the angulation of the central ray, the transfer colon in both flexures not always included, the exposure technique that shows the entire anatomy. This is the PA oblique projection RAO position. The RAO position best shows the right colic flexure, the ascending portion of the colon, and the sigmoid portion of the colon. The evaluation criteria is evidence of proper collimation, entire colon, right colic flexure less superimposed or open compared with the PA projection, ascending colon, cecum, and sigmoid colon, and the exposure technique that shows the entire anatomy. This is our PA projection LEO position. The LEO position best shows the left colic flexure and the descending portion of the colon. The following should be clearly shown as evidence of proper collimation, entire colon, left colic flexure less superimposed or open compared with the PA projection, the descending colon, and the exposure technique that shows the anatomy. This is a lateral projection, a left lateral projection of the lateral rectum. And the lateral projection best shows the rectum and the distal sigmoid portions of the colon. The evaluation criteria is as follows: evidence of proper collimation, rectal sigmoid area in the center of the image, no rotation of the patient, superimposed hips and femora, superior portion of the colon not included when the rectal sigmoid region is the area of interest, and the exposure technique that shows the anatomy. This is the right lateral decavitous position. The right lateral decavitous position shows an AP or a PA projection of the contrast-filled colon. This position best shows the up medial side of the ascending colon and the lateral side of the descending colon when the colon is inflated with air. The evaluation criteria is as follows: evidence of proper collimation, area from the left colic flexure to the rectum, no rotation of the patient as demonstrated by the symmetry of the ribs and the pelvis. For double contrast examinations, the air-inflated portion of the colon is of primary importance and should not be over-penetrated. This is a left lateral decavitated position of the large intestine. The left lateral decavitous position shows APA or an AP projection of the contrast-filled colon. This position best shows the upper side of the ascending colon and the medial side of the descending colon when the colon is inflated with air. The evaluation criteria is evidence of proper collimation, area from the left colic flexure to the rectum, no rotation of the patient as demonstrated by the symmetry of the ribs and pelvis. And for double contrast examination, the air inflated portion of the colon is of primary importance and should not be over penetrated. This is our last image taken. It is taken once the patient has gone to the bathroom and defecated all the barium. And as we can see, there is still some barium in their left. This is a KUB picture, similar as our scout picture that we took at the beginning. This is just to see if there was any barium left in the large colon and intestines. Now that we do see some barium in there, we can let the patient know and give them instructions as what to expect now that they're going to go home after the exam.